first. So you can put all your lines up here. The ventilator's on the right side of the bed. And I should know this because I've been in the seating system for so long. Do you have a standard side of the bed that the vent goes on? That you prefer it on, or no?
Side of the vent?
Side of the bed. So always on the right or always on the left, or
Away
just
from
wherever
the door.
it fits?
It's always away the door.
Okay, so if we were in this room, it'd be over here on the right.
Yeah.
So I would put my tubing either in the center or on the left, because when I turn the patient into the prone position, I'm going to do two things. I'm going to put the circuit opposite the vent, so that when I flip the patient, the circuit's right next to the vent. And secondly, I always want to rotate toward the vent. Okay, always rotate toward the ventilator. So where Catherine is on the buttons down there, you're going to set it to go. The vent's here. I'm going to set it to go counterclockwise because I want the patient to turn that way. Imagine if the patient is the vent's here, and I turn the patient 180 degrees down this way. So I'm turning away from the vent. So there's the risk for extubation. So you always want to prone toward the ventilator and 180 degrees, and then you always want to bring them back the opposite direction. You don't want to go 360 degrees. You want to go down clockwise or counterclockwise and come up the opposite direction, okay? So once I get the patient situated here, and I'm sure that when I put the face mask on, you don't actually have to put it on if you still need to do the dressings to the face and so forth, but before everybody leaves the room, come over and look at the patient, make sure that you can see their eyeballs right through here, okay, and that the ET tube and their lips are right here. These shouldn't be on top of their lips, and this should not be on top of their eyeballs. You also don't want to pull this back where the metal bar is what's resting on the patient's nose, and they get this gash across their nose, okay. This pad needs to be here where you can see their eyeballs. These adjust up and down, so these screws, these Frankenstein bolts here, can undo, and then you can move this up and down to adjust where the opening is here, how wide the opening is. And these are Velcroed in right here, so you can pull these down to support whatever part of the face you need to support. So if I make these longer, I can bring these down longer, okay? Does that make sense? There's an extra set of face packs that are packed in the bag, in the black bag, okay? And they're here. So in 48 to 72 hours or before then, say the patient has a bleeding dyscrasia and they have a lot of blood, we all know what old blood smells like, and they're just stinky, and you're able to turn the patient over, you can grab the extra set of face packs, just rip these off, you just pull it off here, and the whole thing will come off. And you can switch them out. But call me and say, hey Tara, I took the extra set of face packs off, and the next time you come through, you bring me an extra set, and I will. I usually have an extra set of everything in my car, so if I'm in town, I'll run by and bring you some and then steal some more from the service center. Okay? So call me if you use those. The same thing with the abdominal binder. When we have the freedom to have extra supplies in the bag, I try to keep those extra, because those get, especially if you have a surgical patient that's using a lot from their surgical side. So if something is gross and you want to switch it out, just call me and ask me to bring it to you, and I will, or I'll call Colton or Victor to bring it. Okay, so I'm going to put the face pack on.
Did you say that's the hardest part to get right? The face?
Yes, it is. It is. Especially on a patient that's a really large, like a morbidly obese patient that's no neck, and you're trying to get them up where this isn't jabbing into. This used to not be a U-shaped pad. This used to be just straight across, and they would migrate, and this would be on the patient's shoulder. So I am, and you know, anything improvement-wise that you guys think that we can do differently. I am the clinical liaison to research and development and engineering, and if you guys think this voice is squeaking, irritating, imagine me really wanting something from you and calling you over and over again. So if you submit those to me, we've gotten a lot of good input from clinicians like you guys. I don't ask the guys in the ivory tower, what do you think we should change on the Rotoprone, because they have no idea. They would put racing stripes on it, like we don't care. What we needed was some place to put our transducers, which when I'm transferring my patient over, we went and measured, and we measured how wide the clips are that clip onto the pole where we're putting all of our transducers. So you can fit them too wide and too deep on this pole, and so that you can get rid of an extra pole that's in the room, okay? So you can line them up with the apex of the heart. So you know how the clips, you can go in one side, down, and up, and then down, so you can fit too deep and too wide. You can also put if you have any hemodynamic syringes or whatever that you need on there, or if you have a patient with a lot of IVs that has a bridge, you can secure the bridge there. Otherwise, when you prone them, that's pretty heavy. It puts a lot of weight on that. Sometimes on the side, on the insertion side, or on the rest of the lines. So you can Velcro them here as well. And you can use the top and the bottom of it, okay? So I'm going to move all my lines over. These lines, these holes right here, 5 or 6 lines can fit in each one of these slots, and believe me, we've seen every slot full with 5 or 6 lines in it before, right? So ET tube can go here or here or here, and then all your transducers can go here, so you can get rid of, an extra pole by doing this, okay? So once the headpiece is in, you're ready to go. Make sure that the face has the Mepalex on it, and if the patient has like a bony prominence, or you guys are level 2, so you guys do get trauma here. So if their face is really, has some areas on it, I would probably put an extra thicker foam, but a hydrophilic one like Copa or Alleven or something that's going to help wick the moisture away, but then provide that extra on their face. So here's the biggest thing with face breakdown. If your patient looks like they've been through a meat grinder when they're on the Rotoprone, it's usually user error, because if you look, and I did a root cause analysis on a high utility account that was having a lot of skin breakdown, and I was like, are the patients septic? Like, have you seen an increase? Like, what's the common denominator with that patient? Are they septic, so they don't have good perfusion to their faces? Is there a new something that you're using that's caustic to the patient's face? And what I realized was, after educating 120 some odd nurses, making every one of them do the face pack, is that, do you hear this is 1 click? 2 clicks. Okay? So so as hard as I can pull on that with my G.I. Jane grip, I am not going to get that face pack off. It is not going to come off. Here's what most people want to do. Okay? They put the face pack on. That's about 452 clicks too many, right? So now the patient has pressure on their face, and they are septic, they're on pressors, they don't have good perfusion to that area, they're hot and sweaty, and now they have their head in a vice because you've tightened it so tight they have pressure on the front of their face, on their orbit, and on their occipital. So they're at a really high risk for breakdown. Okay, so it just barely has to kiss the face. Okay, for me, I'm Italian, that's easy to remember because we're real kissy-kissy, so just barely has to kiss the face, okay? Just 2 clicks, all right, is all that you need. Do not push it down really, really tight. There's a situation where you have to do that, and that is when you prone the patient, and and they have a big, heavy head, and there's not enough room for the circuit to fit between the face mask and the bottom part of the hoop here, and I'll show you that just so you can eyeball to see what I'm talking about. You can push it in a little bit, but it never needs to be flushed up against there, okay? So you can see you have a lot of room for lines or whatever it is that you need to feed through here. I've had a couple of CVBHCs or CRRTs that we fed through here as well, okay? All right.
Tara, can I ask a question?
Yes.
Where's your most likely breakdown going to be?
I usually see it on the face or on the bottoms of the feet.
The feet and the
Okay.
face, okay.
Feet and the face. What about you guys?
Just the cheeks,
Right.
Well, the first one we have
the
is the
nose.
cheeks.
Right.
What's the name?
Joel.
Jaw. And
Right.
then after that, we don't have that much. But
Right.
Well, we
the
started,
feet.
so now what you need to do, as soon as you find out that we're going to do Rotoprone on someone, you have to do a WOCN consult. And if it's during the day shift, they'll come in and they'll help you prep the patient before the bed actually gets here. If it's not here already, they'll help you with the Mepalex, and now that Joel's gone, I don't know if
I was
that'll
about to
work.
say, who's here? Who does that?
But you know what, Tara, the only thing that I don't know that I've just learned right now is just 1-2 click on that thing and that's it. It's just
That's new for us.
Right. So most people want to jam it down on the face. Even if you do 2
But-
or 3, that's okay. But you can see how many options are of clicking down.
Yeah.
Right. I mean, you can just keep going, and that's by the time that a 12-hour shift is over and you've done what you need to do, it's jammed all the way down. So that puts a lot of pressure on
The only thing that we always kind of keep in mind is I can see the eyes and I can see the ear.
Right.
Because I was thinking when you're on the patient's if it's loose, it's going to be, the head is going to be.
Right, so I'm going to show you something as well, because they were saying, what about this morning somebody said when you prone the patient, it just looks like their head, they're hyperextended, and a lot of times that's the hips aren't padded, or the chest pack has too much padding or not enough padding in it. So you can add and take away from that, but also sometimes you can use the head crank to adjust the head up or down on the patient. And I'll show you how to use the hand crank to do that. Most of the time you don't have to mess with it. This should always have this bar underneath right here, should always have 2 finger breaths. Otherwise, they're, and it's part of the QC process, but there is, you have to leave room for human error. Sometimes it's cranked way down, and then the patient's head flops. But if you do have a patient that's got kyphosis, or a patient that's really, really large, so that in the prone position or in the supine position, their head drops real far back. So, that actually compresses the airway as well. I'll show you how you can crank the headpiece to help to correct that once they go over.
So if we get, so I have to ask this because I've never seen one of these
Yeah.
before, but if we get a patient and the first thing we do when we transfer them over to the Rotoprone would be adjusting the head, correct? Getting this right before we do anything else, adjusting the face.
Just because there's 5 or 6 people in the room, so if the patient needs to come up or go down,
Yeah.
and then it's also happened to me when I first started, I get the patient totally packed in, I'm like, man, that looks good, and then I go to put the face pack on, they're 2 inches too low, so then you have to get withdraw if you pulled it out and all that. So I try to get the face situated first because that's where you have the most help, and it's also the piece or the part that makes people the most nervous. So, when you put the face pack on the patient, when you're ready to go, their ET tube, their head's here, everything is already intact. All of your lines have to run through the head of the bed. I typically will come in at an angle like this and then around where I can incorporate the tube this way and around instead of going straight down. You can come in this way if you want, whatever works for you. I mean, we all have our own style of doing things. Mine's always the best, but you can use it if you want. So anyway, you want to just whatever works for you. But once it gets in there, and it is, make sure that you have your hips pushed up against here so that then you're not all the way up here. And then when the patient does move down, then you really have a problem with the patient with no neck being positioned properly. Does that make sense? Any other questions up to this point?
And you won't be alone.
Yeah.
Right, you'll have help. So when you transfer the patient, you can use, let me tell you this, you can use a slider or you can use a side rail. And I use this. And I teach this all over the place because us nurses are so innovative. I just use this to bridge the gap. Okay? So I just put this here and slide the patient over that way. The slider boards, the regular slider
do it
boards
again? I didn't see
are
that.
too long to side rail.
Oh, okay.
The regular slider boards are too long. You have to lift them up and over the foot piece here. So unless you have just a half a slider, it's really difficult. So I use this up next to up to the bed that you're going to transfer them off of. So that's just the side piece there. Okay. So up to this point, no questions, right? If you do have a massive, and no question is a stupid question because if you don't know, you don't know. All right. So I'm transferring my patient over. I'm going to get them situated, and I don't have to put this on yet. You just want to make sure that the patient's lined up, which is for me. I'll go, hold on, guys, before y'all leave. Let me check. Okay, that looks good. Okay. All right. So transfer the patient over. Now you're going to build the Rotoprone from the inside out and the bottom up 3 times. So inside out, bottom up, bottom up, bottom up, and then we'll be ready to go. So if I'm building it from the inside up, what's going to go first? So you guys do it because I know how to do it. So somebody go put the next piece in.
You're saying that the head is already
The head's fixed.
Fixed,
The
okay.
over, the head's fixed.
The patient's
So you said it.
Oh, you said you.
Yeah, you did it. You said it right.
Alright, ask questions. You gotta do next time.
Yes. So prior to the last reefer, this was a solid piece without gutters, without a handle. So it's very difficult. So how it goes on makes sense. The handle's going to be up, and these prongs are going to go down, so you can set them inside. Set them inside the hole there. And then can you guys see this that don't know? Then you're going to turn this right here, and then we'll lock it into place, okay? And if it's not locked into place, when you turn the patient to the prone position, it will wobble some, okay? And then once again, you're going to adjust the feet here. With this, adjust up and down, okay? You want the patient's foot to be flat up against there. You want the patient's foot to be flat up against here. Okay, when we talk about where do you see the breakdown the most often, it's on the face and on the feet. So once the patient's in the prone position, and you open the bottom hatch, you can actually do range of motion with the patient. If I come and help you with your nursing care, a lot of times I'm going to say, have we done this, have we done that, have we done range of motion? So you want to try to do that. In addition to, if you're trying a supine trial with the patient, there's lots of different pads in here. If you're doing a supine trial, in this pack there are these, I call them pizza wedges, okay? Looks like this. I will actually put it under the patient's calf and offload their heel, so that in the Rotoprone they're like this and the heel's totally offloaded, so the heel is not touching the bed at all. So once you start supine trials where you're doing 2 to 3 hours in the supine position, this is a pressure redistribution surface, but it's not one that I would choose to land for a really long period of time on my back. I mean, it's nice and soft, but it's not going to distribute pressure in your high contact areas. So I try to offload the heels on here, okay? And those are in the bag right here. So I build it from the inside out. What goes next?